Dear students, welcome to this virtual 319 lecture. This is going to be probably the longest one because it covers a large amount of epithelial tumors, mostly carcinomas. As usual, I suggest you to check out the companion lectures because I have a lot of clinical pictures there and also a lot of theory, which is essential for understanding this very complicated topic. My usual disclaimer, these are the lecture slides, not the examination slides. For the examination slides, check out the respective lectures. So let's start with the first one. We start with something non-neoplastic, basically a pseudotumor. I will start talking about lesions of the skin now, of keratinocytic origin. So the first one is a very common benign lesion, non-neoplastic, the fibroepithelial polyp. I am just showing it to you because you're going to see it a lot on patients, so you just may recognize it. So here we go. Here's the virtual slide. It's a polyp. The stroma is composed basically of reticular corium, which has expanded with a lot of blood vessels, so it can be a bit reddish. And on top, you see just regularly differentiating squamous epithelium, keratinizing, which is the epidermis. This is just a cosmetic problem and it can be easily removed by catching the stalk. Look how long this was. You can get very big ones on the skin and you can also get quite long ones in the perianal area where they are related to hemorrhoids. Look, here is the place where it was removed. Here's the base, so we have a nice long lesion. So it has no malignant potential, there's no dysplasia. Let's move on to the next one. Now we have another very common lesion, very frequently seen. You see it especially in old people, seborrhoic keratosis, or verruca seborrhoica is another name. This is also a benign lesion. I think this one is neoplastic, but I'm not completely sure. But nevertheless, it doesn't have any malignant potential. Let's check out the virtual slide. Here we see a big one. They are of a variable sizes. Most of them are just a few millimeters across. This one is big. This one is 17 millimeters in diameter, so quite large. And let's check out the typical features. So we see that the epidermis is irregularly thickened and more complex in architecture. So acanthosis, that means thickening of the epidermis, especially here you see. And here we see this very odd type of keratinization, like this. This look like balls, whorls of keratin here, and this is the so-called squamous eddy. We get something similar in look in some squamous cell carcinomas. Those are the so-called chancroid pearls or keratinous whorls. Those are different. This is just normal keratinization, but it has become stuck in this area. So this is a benign lesion with almost no malignant potential. And it's just a cosmetic problem. It can be removed completely and then the patient is cured of it. Remember, especially in old people, they can look quite ugly, they can be quite pigmented. Here we see a lot of pigment, so frequently you mistake it with a nevus. You can mix it up with a nevus due to pigmentation, and otherwise they are just a cosmetic problem. Let's move to the next one. Now we move into malignant territory. We start with squamous cell carcinoma. Remember one of the previous lectures we talked about actinic keratosis and the squamous cell carcinoma in situ, also known as Bowen's disease. Well, if it becomes invasive, if these two lesions progress into invasive cancer, then this is the cancer that we get, squamous cell carcinoma. So one huge disclaimer for squamous cell carcinoma, you have squamous cell carcinomas all over the body. You have it in the esophagus, for example, you have it in the genital tract like penis, vulva, vagina, cervix, you have it in the lungs, you can have it in your bladder, you can have it in your mouth, even in your nose, on your tonsils, in your larynx. So these tumors essentially look very similar to each other. Histologically, they are almost indistinguishable. But remember, these are genetically totally different tumors, and they are caused by different risk factors. Squamous cell carcinoma of the skin is in most cases caused by UV radiation, chronic exposure to UV radiation. But if you have squamous cell carcinoma in the genital tract, well, obviously it doesn't get all that exposed to UV radiation, because you don't walk around naked all the time, maybe just sometimes if you're into that. But these cancers arise mostly due to HPV infection. So carcinoma of the genital skin, on the vulva, on the penis, that's almost exclusively linked to HPV infection. Or there are some other inflammatory conditions, but most of the cases are HPV related. So remember this is important to understand. So not every squamous cell carcinoma is made equal, and they also behave rather differently. You can read about this in the theory. Now we talk about morphology. So here we see the normal level of the epidermis as I'm moving my cursor, and you see that something big, something polypoid is growing out, almost like a fungus. We can also use the term fungating. So it's growing out. Now we check it out. We can see that there is some, it resembles the normal epidermis a lot. So you have something which is sort of a basal layer, then you have something which is sort of a stratum spinosum, and it's also sort of keratinizing, but in an irregular way. So here single cells are keratinizing, and here we have a lot of parakeratosis. Remember, parakeratosis is when you have a nucleus still left over within the keratinized cells. So there's a lot of parakeratosis, but the entire thing is in disarray. Here we see like very high mitosis, which is also atypical. So this is basically a caricature of the normal epidermis. This is well differentiated keratinizing squamous carcinoma. Another very broad term that I like to tell is that imagine that the carcinomas are essentially the caricature of the tissue from which they come from. So carcinomas, they try, at least the better differentiated ones, they try to resemble the tissues which they come from. So squamous cell carcinoma is trying to resemble squamous epithelium, intestinal type adenocarcinoma of the colon. It's trying to resemble the Lieberkühn crypts and so on. Urothelial carcinoma of the kidney is trying to resemble the urothelium, but they are not doing a good job at it. And we, thanks to morphological analysis on histology, we can see that this is not alright. This is only just sort of looking like the normal tissue, but it isn't. If the tumor becomes gradually more poorly differentiated, if the tumor is extremely poorly differentiated, that in many cases we cannot even tell the lineage. So you can have tumors which are so poorly differentiated that we cannot even tell whether it's an adenocarcinoma or a squamous cell carcinoma. We call these tumors like anaplastic carcinoma. We could use the term anaplastic carcinoma. There are even lesions which are so poorly differentiated that we cannot even say whether it's a sarcoma or a carcinoma without extensive immunohistochemical evaluation. So this can be quite complex, especially in the case of metastasis. So remember, depending on the degree of differentiation, the malignant cancer, especially carcinomas, are going to resemble the tissues that they come from. This also applies to sarcomas to a certain extent, to some types of sarcomas. Some of them resemble their original tissue, like well-differentiated liposarcomas. Others, we don't even know what kind of cells do they come from. So remember this. I suggest you to read about the theory regarding this skin cancer, especially squamous cell carcinoma. We like to ask this a lot. Look at this nice keratinization on a single cell level. Here in the cytoplasm we see some keratin. So this is all in disarray. Here we see these irregular groups of cells. When you compare it with Bowen's disease, we see that there is no basement membrane left. In general, for a carcinoma to be declared as invasive, it has to have breached the basal membrane, the basement membrane. Here there's no basement membrane left, essentially. So it has been breached. Definitely here's the depth of invasion at this level. I mean, even though the tumor is quite big, it isn't really invading all that deep. This is good, because this tumor has been completely removed by this excision. So there's going to be a big scar left. Maybe the patient needs a skin graft. We get a lot of big excision specimens here from our hardworking colleagues in the plastic surgery department. And this is something that we get all day. In our population, we have a lot of these tumors. So let's move on to the other very common squamous tumor, malignancy originating from squamous epithelium, and that is basal cell carcinoma. So squamous cell carcinoma, it resembles the stratum spinosum. Basal cell carcinoma, well, it remembers the stratum basale of the epidermis. So let's check it out. Here we have this lesion. This one is rather small in contrast to the big monster that we saw in the previous slide. So here you see it's well circumscribed. Well, most cases of basal cell carcinoma, they are well circumscribed microscopically, but upon macroscopy, so clinically, it can be very hard to tell where the basalioma or basal cell carcinoma, these are synonyms, basalioma ends. So let's zoom in. This one resembles the stratum basale. So the cells are small. They have like this this uniform nuclei. But we can see that something's up because there is some atypia, and we usually also see some mitosis, which I'm not seeing any here. So the tumor has let me down. But here are some mitosis. We also see them in the middle of the islands of this basal cell carcinoma, but this tumor has let me down. But another feature that we see in basal cell carcinoma, look at it here. So we have this nuclei at the periphery, which are arranged like parallel to each other, once again like a picket fence in front of the American suburban homes, the white picket fence, except this one is purple. So a picket fence with a fashion sense. Yeah, I'm funny. And this is the so-called peripheric palisading. This is typical for basalioma. So this tumor has been excised completely. Most basaliomas are cured by being completely removed. Sometimes it's extremely hard to remove them. Some subtypes grow more aggressively. This one is relatively slowly growing. I will have some nice clinical pictures of more aggressive cases. So remember, basal cell carcinoma, this is the most frequent malignant tumor in our population, especially in this country. In Africa you will have much less of them because they have the right skin color for their sunshine. Here we don't as much. So let's move on to solid organ tumors. Let's start with the kidney. So here we have a PAS stain. Now here's the kidney, you see the glomeruli. I'm using the PAS stain because we had a lot of PAS stains left over from clear cell carcinoma of the kidney. So even with PAS, you can see that they have a clear cytoplasm most of the time. It looks almost the same in H and E, it's just a bit less pink. Here you see sort of clear, slightly eosinophilic cytoplasm. Here some granules are catching in the PAS stain. This is because these cancer cells can contain varying amount of glycogen, not collagen, glycogen. So here some of them are catching a bit more, so these cells contain a bit more glycogen. So essentially clear cell carcinoma of the kidney is the most common malignant kidney tumor in adults. It's usually arranged into solid areas like this, but it can be also like this glandular, like this gland-like structures, but it tends to be mostly solid. There can be areas of necrosis like this. You might recognize these structures here. These are cholesterol crystals. As I've already told you, these cells contain a lot of lipids, so if these cells undergo necrosis, then a lot of cholesterol is going to be released. Here you can even see some foamy macrophages. You see, if you look really close, you can discover a lot of beautiful details in the histological slides. So foamy cells eating the lipid. These are benign macrophages. They are just doing their job. They don't know that they are doing it within cancer. They will never know. Such is the tragedy of their work. Here we see more cholesterol crystals in an area of coagulative necrosis. Well, sort of. Maybe this could even be called liquefactive. Yeah, I would call this liquefactive necrosis within this high tumor of high fat content. So what we check for every time in kidney cancer is whether it invades into some kind of blood vessel. Here are some blood vessels. It likes to invade into veins. So this is the artery. Here you see the elastica interna, lamina elastica interna, this wavy thing here, elastica interna. And next to it, here are some companion veins, which are all clear. This tumor likes to invade into veins, and also we check whether the tumor is spreading outside of the kidney, so whether it's spreading into the hilus, into the fat of the kidney hilus, or whether it's spreading into the perirenal fat. Here I don't have any of it in this slide, so I cannot tell. These tumors can be quite large, so this is still okay. It was probably much larger than what you're seeing. So this is clear cell carcinoma of the kidney. Remember the basic histological features, remember why the cytoplasm is clear, and remember what we check out for. Let's move on to the next one. Now we move on a bit lower and we start to talk about urothelial carcinoma and its different subtypes. So urothelial carcinomas are extremely common in our population. We have a lot of patients here. Our urological department is keeping us quite busy with a lot of biopsies, which is good. And now I will show you what it looks like in microscopy. So we divide basically urothelial papillocarcinoma into invasive and non-invasive. Here I have a case of non-invasive urothelial papillocarcinoma. I think your examination slide is also non-invasive. This is basically an in situ lesion, and we can see that it hasn't breached the basement membrane. You can see how well all these tumor groups are circumscribed. There's no obvious invasive growth. There has been no breaching of the basement membrane. Look how nice and smooth the contours are. This is important. And now I will explain to you why is it called papillocarcinoma. So let's talk first about this organ. Here you see that it's a part of the urinary tract. Urothelial papillocarcinomas can develop anywhere where you have urothelium. So from the renal pelvis down to the ureters, to the urinary bladder, until the urethra, within the prostate and within the penis. In males, you can develop urothelial carcinoma anywhere. So let's check this out. We see here there's a layer of muscularis propria. So now I will give you a few seconds to think about what do you think which part of the urinary tract this is. And if you thought that it's the bladder, then you're wrong. This is probably from the ureter or maybe from the pelvis. So great, it's an upper part. So this is quite unfortunate because if you have it above the urinary bladder, then they have to take out the ureter and you also lose your kidney. So that's quite unfortunate because you lose a kidney which is working, but I don't think there's any way to connect the systems again. We don't have any like artificial ureters, anything like that. I'm not aware of it. So unfortunately you lose your kidney in most cases if you have something like this. It also, especially if it's large like this, imagine that this highly dilated ureter has been totally blocked. So no urinary flow was possible, and this patient probably developed hydronephrosis, which leads to gradual atrophy of the kidney and loss of kidney function. So the kidney probably had to go anyway. But sometimes they lose completely functioning kidneys, which is a shame, but there's nothing else to do. So we have the organ. Now let's check out the histological features. We call it papillocarcinoma. So the first thing that you will notice is that, as I've already hinted upon, this cancer is trying to resemble the normal urothelium. So there is a multi-layered sort of columnal urothelium or transitional epithelium, but you can see that it's very high. So normal ureter is like 3 to 5 cell rows high, but this is double or triple it. So as a rule of thumb, we say that if it's higher than 7 cell layers, so if it's higher than 7 levels of nuclei, then it's a neoplastic. So this is obviously higher than 7, this is even higher than 14. So there's nothing really to think about here. We also evaluate the nuclear features and the degree of atypia. The higher the atypia, the bigger the chance that it's going to invade. So we have settled that it's higher, it's neoplastic, and now what about the papillo part? Because it forms papillae. Papilla is an elongated like villous structure with a fibrovascular core. So this is a textbook papilla here. Now I zoom into the fibrovascular core. It contains collagen and vessels. This is why it's called fibrovascular. So this is all the apparatus that supports and feeds the papilla of the papillary urothelial carcinoma. In the bladder, well, you see it as a exophytically growing like a polypoid lesion with many pointy papillae. So in the urinary bladder, it's quite easy to remove through electrocautery. So you have basically a loop which is heated up and it's burnt out, and the samples are sent to us for evaluation. And this way you can control the disease for a long time. As I've already hinted, if it's higher up, then you will probably lose your kidney along with the ureter that has been affected. So this has been a urothelial papillocarcinoma. Let's move on to something else. Let's move to the prostate. In the prostate, the most common cancer is the so-called acinic adenocarcinoma, or acinic or acinar, with a C, acinic, because it resembles the acini of the prostate. I have already spoken a little bit about the distinction in in the slide about benign prostatic hyperplasia. So if it's invasive, the carcinoma, then you don't have the outer layer of basal cells surrounding the glands. So let's check out. Now I'm going to have a textbook example here. You see here are these little glands everywhere. They are quite irregular. They are even getting out of the prostate into the periphery. Here, this is a peripheric nerve. So they are even spreading. You see here, this is a nerve here. They are spreading along a peripheric nerve. So this is the so-called perineural invasion. This is a sign of aggressive behavior. Here's another small bundle of peripheric nerves. So this is a sign of aggressive behavior. These irregular glands. Here's another one. Look how nice. Here's another nerve. So there's massive perineural invasion by these very irregular glands. You see that they are very haphazardly arranged. Some of them are very simple, tubular, but almost all of them are very complicated. You see it makes this Roman arch-like structures or cribriform structures, or they have fused together in this irregular fashion. These are cribriform glands. Read about Gleason grading. I have a good illustration in my companion lecture. So Gleason grading is performed based on the architecture of the glands. We don't care about nuclear atypia, we don't care about mitosis, we care only about the architecture in order to assess the differentiation. And here this would be probably Gleason 4 the cribriform glands are Gleason 4, and since virtually all of them are cribriform, this would be Gleason 4 plus 4. Maybe some would call it 4 plus 3 because we saw very few like tubular glands, but I would call it Gleason 4 plus 4 because both the majority of the tumor and also the biggest, all of the tumor is composed by this cribriform gland, so this is Gleason 4 plus 4. This is quite aggressive in general, so if you have a Gleason score of 8, then there's nothing good to expect from that tumor. We check out a gland, so the typical nuclear feature is the presence of this small vesicular nucleus with a big nucleolus. So small, relatively uniform nuclei with big nucleoli. This one even has two, like two little eyes looking at us. So if we see these nuclear features in a metastasis somewhere, let's say in the brain, then we immediately think of prostate cancer. Or in the bone, it can metastasize to the bone and cause fractures. If you have a fracture of the femoral neck in a male, then you think of prostate cancer. If you have it in a female, then you don't think of prostate cancer, you think of osteoporosis. So you see, you will encounter this from time to time in the emergency room. If a tumor goes undiscovered and causes a pathologic fracture in a male and so on, or unexplained back pain. So this is a prostate cancer, prostate adenocarcinoma, acinic type. Now we jump to the thyroid for 2 slides. I will explain to you the logic behind the 2 most common types. So let's start with the follicular lesions. So follicular lesions of the thyroid are the second most common lesions behind the papillary ones. We will talk about papillary in the next slide. So a follicular adenoma and carcinoma, there are both adenomas and carcinoma, they are quite similar to each other. Similar in that they are usually surrounded by a fibrous capsule. So they are well circumscribed and encapsulated. They have this you see, this collagen, this fibrous capsule is surrounding them. Here, in the case of this follicular adenoma, the capsule is complete. So the tumor is totally and completely surrounded. Then, another thing that we see are the so-called microfollicules. Let's check out the normal thyroid. So this is what normal thyroid follicles look like. These are so-called normal follicles because they are normal. Normal, uninteresting, normal follicles. These ones are a bit smaller because here we have pressure atrophy from the tumor. But if we go here, for example, in this area, you see that these follicles are quite small. So a large proportion of this tumor is made up of microfollicles. Well, not all of them are microfollicles. You see, these ones are normal sized. But if I took a biopsy sample from here, then I would write in my report that I see a follicular neoplasm, which could be either an adenoma or a follicular carcinoma. Both of them look very similar. If I took a sample just from here, I wouldn't be able to tell you whether it's a follicular adenoma or a follicular carcinoma. Okay, great. But how do I tell whether it's benign or malignant? So there are 2 criteria. Criterion number 1, follicular carcinomas, they pierce the capsule and they grow outside. So there's extracapsular invasion. So it grows out of the capsule. Follicular adenoma doesn't do it. So this is criterion number 1. Criterion number 2 is that follicular carcinoma invades into blood vessels. So I have to check every single blood vessel. Here you see a big vascular space. Here you see another one. You check all these vascular spaces for the presence of tumor cells in the lumen. If you see, then it's going to be a follicular carcinoma. Here are these ones. So that the cancer, if it's carcinoma, it tends to invade into these vascular spaces here, for example, within the capsule. So as you see, at least not in this slide, I don't see any signs of malignancy, so there's no capsular invasion and there's no invasion into the blood vessels. Naturally, I have to examine the entire tumor. So if it's something big, like let's say 5 centimeters across, then I'm going to have to get a big cold drink to go through every single slide. It's going to take a lot of time. So these have been follicular lesions. They can be also hyperactive, so they can be hormonally active, especially the adenomas. Now we move on to the most common malignant tumor of the thyroid gland, and that is papillary carcinoma. This has a few typical features. Here we have a big one. This is all just cancer. We have no normal thyroid left. So first of all, recall me talking about papillae in the urothelial papillocarcinoma. The principle of the papilles is the same. We have a fibrovascular core, and on top of it we have these atypical epithelial cells. So this is papillary thyroid carcinoma. You see the papillae. This is one of the typical features. So they can also be follicular. Let's see if we have some follicles. Yeah, here we have some follicles. Great. So it can also form follicles. There is even a follicular variant in which you only have follicles and you need to distinguish that from follicular carcinoma. So this can get quite interesting. These are not boring tumors. Here we have some signs of bleeding. These are all siderophages. Here there's also some hemosiderin here within the stroma. So the first feature is the formation of papillae, which is not always present. Now the second typical feature are the nuclear features of the tumor. So let me find a good nucleus. Yeah, I'm looking for the ideal one. I mean, these are all sort of right. I'm looking for one which is especially good. This slide is a bit overstained. Okay, this one should work here, this group. So one thing that they have is that they have a pale cytoplasm which can, pale chromatin which can be almost like clear, like this one here. It looks almost empty, it looks very pale. This is a fixation artifact. If we worked with it through frozen section, we wouldn't have this. Look at this nuclei, they look also quite empty, this emptiness of the chromatin. This one here as well, this is quite typical. These are the so-called Orphan Annie nuclei. I have a picture of it. Orphan Annie is a comic strip, and you have this very creepy girl with her empty eyes, and she also has a creepy dog. Here is this one, which is quite empty. So someone was reminded of her eyes. Well, at least it's not labeled, at least it hasn't been named after some food stuff, like the other things in pathology. But still, so the Orphan Annie nuclei, that's one of the typical features. And the other typical feature is that they have a nucleolus, like this. So here we see the empty nuclei with the big nucleolus. And I'm looking for a good nucleus for the last typical feature is that many times the nuclear membranes are irregular and irregularly folded. Here you see this one has a very folded nucleus, like a piece of paper which has been crushed into a ball. Basically, so irregularly folded nuclei, empty nuclei. Here these ones are especially clear with the regular membrane and the nucleolus. Here we have a beautiful mitosis. So this has been a papillocarcinoma of the thyroid. This is extremely common in females. It starts in young adulthood. So in your age, some of you may already get one if you're unlucky, but the prognosis is good. So now I make a jump and I will talk about a bit of theory. So here these slides, this will be adenocarcinomas, mostly from the gastrointestinal tract, so from the stomach and the colon. And here I will be explaining to you the growth patterns of carcinomas. So adenocarcinomas, they can have multiple different growth patterns. I've already talked about a few, like the cribriform pattern, the papillary growth pattern, but we have a few more. So we start with the tubular pattern. This is just a morphologic description. You can have tubularly arranged adenocarcinomas in multiple organs, like in the lung, in the intestines, in the stomach, in the pancreas, and so on. So let's check this out. So why is it tubular? Because the cancer is forming these beautiful tubules. Look how well formed these tubules are. Just tubules with obviously atypical cells with big nuclei and nucleoli. So I will try to guess where this comes from. So my guess is that this is either the intestine or the stomach. It could be both. Here you see that these tubules are irregular. They are invading, growing deeper. I'm going to guess this was the stomach, but I might be wrong. It's definitely from the gastrointestinal tract. And what we see as these tubules are invading deeper, once again you see the so-called desmoplastic stroma that I have already talked about, I think, in a previous lecture. So desmoplastic stroma is a mixture of these very active fibroblasts and some inflammatory cells. And these are fibroblasts which are doing the bidding of the cancer. So they are supporting the cancer. They have betrayed the organism. They are on the side of the enemy. So these are essential for survival of cancer cells. If we somehow manage to knock these out, then the cancer will be vulnerable to chemotherapy, and it could be wiped out and treated much more effectively. So this is a future area of therapy if we manage to find the right drugs to do so. So a lot of energy is being invested into cancer-associated fibroblasts. Okay, so this has been a tubular pattern. Remember, it's just a growth pattern. The next pattern is solid pattern. So solid pattern is generally seen in carcinomas with higher grades, so which are less differentiated, poorly differentiated. Tubular pattern is seen in better differentiated adenocarcinomas, so low-grade tumors, and in high-grade tumors we see areas of solid growth pattern. And also remember that the different patterns can be mixed within one tumor, so you can have a part of the tumor which is tubular, part cribriform, and part solid. I think this is going to be the case in this example. So this is stomach. I'm definitely sure about it. Here we have some normal stomach. Well, it's not normal because you see this. These are goblet cells. So we have a big area of intestinal metaplasia, huge area of intestinal metaplasia here. Now let's check out the cancer. So in the upper part, here you see some tubules which have lost their way. They have gone through the lamina muscularis mucosa, to the muscularis mucosa. They have gotten into the submucosa. So this is definitely cancer. Here these tubules are quite well formed. So here you have to really sharpen your eyes and look for some atypical features like this big cell to tell that this is cancer. So these are deceptively nice, deceptively beautiful tubules. Here you might run into some trouble, but if we go deeper, here we see that we have some solid areas. Here the tumor is starting to become much more ugly with solid areas. Here we see some hints of mucin production. This would be Alcian blue positive. Here you see a little drop of mucin. So the cancer still thinks that it's an adenocarcinoma, but it's starting to forget it because it's starting to form these solid ugly structures. So if I just took this, let's say I took only what you see on the screen, then I would have quite a bit of trouble telling whether it's an adenocarcinoma or a poorly differentiated squamous cell carcinoma. Well, the only thing which would help me is here this vacuole of mucin. So this is a high-grade tumor. Here we have an area of coagulative necrosis. And here we have something more, something sinister. These are lymphatic spaces. So this is lymphovascular invasion. So the tumor is behaving very aggressively, and it has even gotten into a lymphatic vessel. And the tumor has managed to spread even through the muscularis propria. Well, we don't see the spread in this slide, it's probably in another slide, but here we see islands of the same tumor which have gotten through the entire thickness of the wall. Here you see a beautiful atypical mitosis. And this is a lymph node, but I don't think there's a metastasis in it. It doesn't look like. So the lymph node is clear, but there are probably other lymph nodes which are positive, because as you saw, the tumor is spreading within the lymphatics. So this is a high-grade lesion. This is the solid growth pattern. So remember, solid and trabecular growth patterns are seen in poorly differentiated tumors, and cancers can have a combination of different patterns. So if we took only this area here, we would say that this is well differentiated, but this makes it poorly differentiated. Let's jump to the next, mucinous. It could be also called gelatinous adenocarcinoma. It's mucinous because a lot of mucin is being produced. This is a nice slide. Here we see the giveaway to the origin. The origin is the colon. So this is normal colonic mucosa, and suddenly we see this. This is quite extensive. Here you see it getting into the submucosa. Here it has gotten into the muscularis propria, the smooth muscle, and it has pierced the muscularis propria, and it has gotten into the pericolic fat. So here's the fat, the normal fat, and here we have this thing. So this is 90% mucin, so this is a so-called mucinous lake. This cancer produces a lot of mucin, and the mucin gets spilled out into the extracellular area. So this is all mucin produced by cancer, and in the mucin we see these epithelial strips, these trabecular and glandular epithelial strips swimming. So strips of cancerous epithelium swimming within this mucinous lakes. Remember this will look like jelly macroscopically, and this is one type of tumor growth pattern. Tumors can be like either fully mucinous, you can see them in the lung, you can see them in the breast, but they are most common in the gastrointestinal tract, or only part of the tumor can be mucinous. That's also a possibility. So we see this from time to time. It's not the most common pattern. Now on to the special stain for mucin production. Here we will have a different case. This is liver. Here's some steatosis. And in this Alcian blue stain we see a metastasis, and all this blue is the mucinous lake. Here you see the interface of the liver, parenchyma with the metastasis. This is probably from the colon. I would say 90% probability that it comes from the colon, and here within this mucinous lake, these groups of epithelia are swimming. Here you see some vacuoles even within the cytoplasm of the epithelial cell. So this is mucin producing cancer. So this is a metastasis of mucinous adenocarcinoma into the liver. Classic picture and a beautiful demonstration of how the Alcian blue stain works on mucinous adenocarcinomas. So we are getting closer to the end, so the diffuse pattern, or the poorly cohesive pattern as it's called nowadays. So diffuse or poorly cohesive. In this case, the carcinoma cells, they don't stick to each other, they separate and they spread diffusely away from each other. They are usually found in a desmoplastic stroma. This is going to be a slide that you will also encounter during our case presentation, hopefully. So this is the stomach. This is the corpus. I see the corporal glands with the chief and parietal cells. And if I start moving a bit down, I see that something's going on here. I see this cell here, which has some mucin inside it. Some of these are the so-called signet ring cells. So just to explain what a signet ring is, because it seems to me that you modern students don't know anymore, even though it's old school even for me. So a signet ring used to be a big gold ring which noblemen used to wear. It was a big and heavy ring, and at the end of it, on the face, you had their family symbol, their family crest, and that's what they used to seal their letters. So they dropped onto the envelope some red beeswax, and while it was hot, they pushed their signet ring into it. This way it was sealed, and when the recipient got it and they saw that the seal was broken, then they knew that someone read their confidential communication. So this is a signet ring cell. So here's another one. This is quite typical. So you have a rim of cytoplasm. In the middle there's the vacuole. The mucin is usually not very well visible, and here you have the face of the ring. Basically this is the nucleus which has been pushed to the side. This is a typical signet ring. Let me find another one. So not all of the diffuse cancer cells are signet ring cells. Here's another beautiful one. Here you see the vacuole, and here's the face of the ring. Here would be the family symbol. And now you see that all these tumor cells are within this very dense collagenous stroma, and let's check out the depth of invasion. So I can see them, I think they got all through, so let me find other areas. They are a bit harder to spot just on H&E. I know that they were massively in the submucosa, and they got also in, here's one in the muscle, I think. Here's another one, I would say. So they're getting quite deep. They are also managed to significantly expand. Here are some other ones, expand the submucosa. So this is diffuse or poorly cohesive carcinoma. Here's a beautiful one of the stomach. And now we are getting close to the end, and we should also mention another carcinoma of the gastrointestinal tract. And that carcinoma is carcinoma of the liver. Hepatocellular carcinoma, this is a huge problem worldwide, especially in Asian countries, where they have a lot of hepatitis B. Here we get most of them associated with cirrhosis, and it's relatively rare, thankfully, because they are very aggressive cancers. So here this case is going to be poorly differentiated. So these cells are not going to have the features of hepatocytes anymore. If hepatocellular carcinoma is well differentiated, then it's going to resemble the hepatocytes. So the first thing that we immediately notice by low magnification are these groups of hepatocytes. This is cirrhosis, so this is a cirrhotic liver. Here you see a nodule nicely circumscribed by the fibrous septa, nodule So this is cirrhosis, and here we see something else going on, something big. So these are very ugly cells. You see the growth pattern is mostly solid insular. You see that this is falling apart because this is post-mortem change. This was from a dead body. Here we see some necrosis. This is coagulative necrosis. Notice the hypereosinophilia of the cytoplasm, and notice the pycnosis of the nuclei. So this is necrotic. Cancer can undergo necrosis, usually because it outgrows its vascular supply. That's the usual reason. So we have this basically multilobular proliferation. It's a very big tumor. And we check out the nuclear features. You see that there's a very big anisokaryosis. That means that the nuclear size is different. Some are big, others are smaller. We see these very prominent nucleoli. So these cells are obviously malignant. They have this basophilic cytoplasm. Maybe this reminds us of hepatocellular differentiation. In a better differentiated hepatocellular carcinomas, you can even see bile production. Well, you don't see it in poorly differentiated ones, so I'm not even going to attempt to look for it. So hepatocellular carcinomas, they usually spread within the liver, so they destroy the liver. And look, here's some beautiful cholestasis. You see here the bile pigment. This is caused by just the presence of the tumor. So these hepatocytes are being interfered with by the tumor, and they are experiencing negative effects in their metabolism. This is why you have cholestasis here. So this is hepatocellular carcinoma, poorly differentiated. If this were better differentiated, then we could even have a hard time distinguishing it from normal liver. These are normal liver plates. So this one is mostly solid and insular in growth pattern. Here we see some vascular invasion. You see this detached group. Here I go closer. This is endothelium. So here we have vascular invasion. This is a sign of poor prognosis. If there's vascular invasion and the tumor metastasizes, it's usually within the liver itself. So you have metastatic satellite nodules at a bigger distance, and quite big tumors can entirely overtake the liver, and the entire liver can be replaced by carcinoma. So this is a very high grade, very aggressive tumor. So this is it for this epic lecture. Thank you for your attention.